Thank you very much. Madam Chairman, dear colleagues, in about half an hour, we'll be discussing the pseudo-lesions that may mimic king disease in head and neck region. We all know that head and neck has a very complex anatomy, and it can be difficult to solve cases if, at least at the very beginning of our career. The best way to cover this complexity is to compare this right side to the left, or left side is the witness of the left in that type of interpretation. It's like a game to find almost two identical images. To find differences is okay, but unless if the background is asymmetric. So asymmetry is our enemy while evaluating in side-to-side comparison. What are the sources of asymmetry? They can be technical problems, improper positioning, maybe a source of asymmetry. Modality-related artifacts can be an issue which will meet a few minutes later. Also, they may be in individual asymmetries, the constitutional asymmetry that cannot be solved with all attempts. Let us look at this patient. The technician tried to obtain the symmetry on the bulbous, on the ocular globe, but the rest are very asymmetric. Variation of any kind, size, location, or position may be sources of asymmetry. Agenesis or unilateral dysmorphogenesis is another source. Surgery, a similar source with the previous one, is a source of asymmetry. Functional disturbances, paralysis, may be another source, and foreign bodies may be another source of asymmetry, which may hinder our interpretation. Let's start with a case. 49-year-old female who has been complaining of migraine for many years. In fact, this young lady is a close friend of mine, came to me and complained of some atypical headache. The next morning, we were sitting side to side to my technician in the MR suite. When the first images reached me, these were the T2 weighted axial images, and there was a peculiar lesion at the back part of the maxillary sinus, which astonished me a lot. Then came the other series. Then I realized that I was just facing a simple sinusitis, but this sinusitis was in a huge sphenoid sinus. I knew this lady since my childhood, but I didn't know she had a huge sphenoid sinus at all. When the sinus is enlarged, but within the limits of the mother bone, it's called the hypersinus. When the sinus grows beyond the limits of the mother bone, that is called pneumosinus dilatans, that may be associated with some anomalies, semiatrophy or arachnoid cysts. Or if the sinus grows beyond the borders of the mother bone with thin sinus folds, then that is called the pneumous cells. In this situation, the sinus may cause displacement of the adjacent sutures. By the way, while deciding about sinusitis, please note the age of the patient, because we know that sinuses grow by age, and we must not be mistaken for a sinusitis in a normal child. Overpneumatization may be another another topic for the temporal bone, especially for the Pitfalls apex. Both Pitfalls apex and other parts of the temporal bone may be pneumatized. They can produce some pitfalls while evaluating tiny anatomical structures, as in this case, and they can be unilateral. In 1/3 of the patients, the Pitfalls apex can be seen pneumatized. It's usually bilateral, but it can be unilateral. Unilateral involvement may be misdiagnosed of pathology on the unaffected side. As in this case, the irritated left part makes us think that the normal fat-containing normal part, fat-containing marrow of the normal part, is a mass lesion, which can be mistaken for a cholesterol granuloma. There are many lesions involving the Pitfalls apex, but most of them are very rare. But the most frequent one is thought to be the effusion of the Pitfalls apex. According to Hansberger, 500 effusions account only for one cholesterol granuloma in Pitfalls apex lesions. On MRI, it's a bigger problem to decide and to differentiate a cholesterol granuloma with a normal site. In this case of cholesterol granuloma, we can see the affected site looks brighter than the fatty marrow, and on post-contrast series, a ring type of enhancement can be seen in cholesterol granuloma. Asymmetry may also involve both types of the cisterns, as it is seen in this case. On the right side, the cerebellopontine angle cisterns are larger than the left side. Or sometimes the flocculus may look bigger and asymmetric on one side, which can be mistaken for a lesion in the cerebellopontine angle. Secretion may be another source. In this case, there's a true lesion on the right side, the squamous cell carcinoma of the external auditory canal, but there is a suspicious lesion. In fact, it's a secretion. We can define the secretion with the air-containing structure, as in this case. And enhancement of facial nerve is maybe another issue. It can be seen bilaterally, especially the anterior part of the tympanic portion of the facial nerve may enhance, and sometimes we can see that the vertical portion may enhance as well. It's easy to decide when it is bilateral, and it's a result of the perineural venous plexus, but sometimes it can be asymmetric, as in this case. In this case, the right side, the facial nerves, looks bright than the left side. In this case, we can only use the clinical signs to find the correct answer. While dealing with the tiny structures of the skull base, sutures may mimic fractures, especially in trauma patients, as well as prominent emissary veins. When bilateral, it's easy to decide. If we have suspicion about fracture, we can check the cortical bone facing the loosened area and decide for a prominent emissary vein or a suture, a simple suture. Enlargement of jugular foramen is a well-known occurrence and may mimic tumors, glomus tumors. Glomus tumors may look similar with the enlarged jugular foramina. Well, the nature of the glomus jugulare is expansion and distraction. We can recognize a simple enlarged jugular foramina with this tiny spur that differentiates the nervous part from the vascular part of the jugular foramina. A different case, there's a nodular lesion on the right side. Is it a lymph node? Let's follow it downwards. It's moving anteriorly and inferiorly. No, this is not a lymph node. It's the dilated anterior jugular vein. We have three main components of the venous system of the head and neck. One is the largest one, internal jugular vein. The other one is the vertebral vein. And the third one is the external jugular vein, which have some connections of both sides and arrange a network that drains the anterior part of the neck. Pitfalls caused by veins may be because of variable anatomy and size, side-to-side asymmetry, lack of contrast in non-contrast images. For example, internal jugular vein may look like a lymph node, and variable degrees of enhancement because of improper bolus timing may cause confusion on CT images. And on MRI, veins may vary because of interstice phenomenon, in-plane flow, flow turbulence effects, and variable enhancement patterns. In this particular case, on T2 weighted images, it looks like there is a thrombus on in the jugular vein, but the post-contrast images clears it up that it's only a vascular phenomenon that can be encountered only on CT, on MR. In this case, with recurrent cancer, we can easily see the cancer on this STIR image. There is a thrombus on the right side, but there is similar images on the left side, which can be a thrombus can be discarded by this T1 weighted images, or we can use a different modality to come to an end. This CT was taken before the MR examination, and it clearly shows that there's a thrombus on the right side, but the left side is normal. Another case, a 70-year-old male who has been treated for mantle cell lymphoma and came back with a suspicion of recurrence. There's a small mass lesion, hypointense on both T2 and T1 weighted images. It's looked like this on the sagittal plane, and on STIR images, it looks bright. Can it be a dilated anterior jugular vein? This time, no. It's a simple but malignant lymph node located anterior to the tracheal cartilage, the Delphian lymph node. Some variations may also occur in the arteries. The aberrant course of internal carotid artery should always be stressed and highlighted in our reports to avoid any fatal surgical procedure. Look at this case. There is a almost aberrant course through the backside of the pharynx. Let's follow. In fact, there is another mass. This is the goitre extending retropharyngeally. So a normal tissue may enlarge to a different place that may mimic some other pathology. Here's another case of 80 years old male complaining of dysphagia, and he was found to be an extrinsic mass in oropharynx. I was sitting this time with one of my residents and checking his preliminary report. He was right. For the giant osteophytes, that was the cause of the extrinsic mass impression during clinical examination. He also had an outpouching directly related to the air of pharynx, which can be easily called pharyngeal diverticula. But he was wrong for the left-sided mass. He called this one the normal appearing left submandibular gland as a mass. In fact, the right was missing. It can be either a consequence of a congenital malformation, or we can see the absence because of a surgery. In this case, with total laryngectomy years ago, and who received radiation therapy, left side of the tongue looks more solid than the right side of the tongue. Is there a mass on the left side? This is a result of denervation atrophy. In long-term patients after radiation, denervation atrophy can be seen in that cases. In the early phase of denervation atrophy, the affected side may also enhance on post-contrast images, which can mimic a mass lesion. Operation is another source. This time, in this patient, the left vocal cord was operated because of the squamous cell carcinoma, and on the right side, there's a suspicion because it protrudes through the air column. This is a normal finding, which is thought to be caused because of the Bernoulli's effect. Bernoulli's effect is a matter of fluid dynamics. In this case, it's not the fluids, it's the air itself. After the closure of the glottis, the pressure increases. The pressure caused by the air increases below the vocal cords, reach to a point that forces the vocal cords to abduct, and then after a pressure depression occurs below the vocal cords, which acts like a vacuum effect to the vocal cord itself. It can also be seen in paralysis. In this case, the left side is the paralytic side, and there is no mass on the right side. This is just simple protrusion because of as a result of the Bernoulli's effect. It looks similar to a real tumor in another case on the left side. So we have to know the signs of vocal cord paralysis. Thinner vocal cord, the most impressive one is, I think, the enlarged descendant ventricle, enlarged piriform sinus, thickened area epiglottic fold are the signs of the vocal cord to the side. On this PET CT images, the right vocal cord looks bright, but left doesn't. This is a result of a paralysis because of a tumor in the thorax, paralysis of the recurrent laryngeal nerve that causes this dissimilarity. So the CT slices can guide us to a conclusion of the paralysis. There are many other well-known pseudolesions regarding PET CT, the brown fat can be mistaken for a mass, but it can the CT image can easily discard this mass suspicion. Lymphoid tissue may also look bright on PET CT images, as well as some normal salivary glands. Another case. This case is 71 years old male. He was complaining of epistaxis, and he was referred to the MR unit with the suspicion of a mass in the middle meatus. Let us check. There is only simple sinusitis on the left side, but nothing else. On axial images, where there is a suspicious mass lesion on the left side, which is hypointense on T1 and no enhancement on post-contrast series, and slightly hyperintense on T2 weighted images. This is a pseudo-lesion. It is a piece of cotton wool which might have been inserted by the patient himself before reaching the MR unit. Also, we can come across to some different types of foreign bodies, like this sugar cube, and it's quite simple, but this also can cause some misdiagnosis as well. In summary, pseudolesions may occur because of technical issues, improper positioning. We have stressed the modality-related artifacts. Constitutional asymmetry may be another source for pseudolesion. Variation of any size, position, location, or size may result in pseudolesion. Agenesis or unilateral dysmorphogenesis, together with surgery, may be another tricky point, and functional disturbances, paralysis, may cause all the pseudolesions as well, like foreign bodies. Awareness of all kinds of pseudolesion, either technical, individual, or pathological, with the knowledge of patient's data, complaint, history, clinical and laboratory data, with the detailed knowledge of anatomy, physiology, and pathology is the main way to overcome this kind of pseudolesions. I thank you for your attention.